Okay, we'll go ahead and get started. Again, my name is Leanne Foster, and I am a provider outreach and education specialist here at WPS Government Health Administrators. I know some people were joining as we get started, so I'd again like to welcome you to our webinar on provider enrollment critical access hospitals. I am going to start with our disclaimer today. I just want to make sure that everyone is aware that our education today was created and questions will be answered based on current CMS regulations and policies. As you know, Medicare changes often, so please be sure that you continue to monitor both CMS and WPS websites for all current rules and regulations. Also, photographing, screenshotting, and recording of this education for profit-making purposes is prohibited. As I mentioned a few moments ago, we are recording this session, so there's really no need for you to record that. We are recording that so that you will have that available to you as soon as possible after this session, barring any technical issues with the recording. We will be posting today's session on our YouTube channel along with our encore presentation section of our training center on the GHA website. That's going to allow you to take a look at it again if there's anything you missed, any questions that you have, or if you know of someone who may benefit from this session and the information shared, you can absolutely send them in that direction. So it will remain available as long as the information is relevant. That brings me to our agenda for today. So the focus today, as I stated, is going to be on the provider enrollment process and eligibility requirements for critical access hospitals. So we are going to talk about what qualifies or who qualifies as a critical access hospital. And we're going to talk about what the enrollment process looks like for CAUSE. It works just a little bit different. They are an institutional provider. There are a few extra steps that involve CMS. So we will talk through all of that today. We will talk a little bit about billing. I won't be going into specific services and those step-by-step instructions, but with CAUSE there is the option to bill what's called Method 2, which will allow a CAUD to bill for some professional services on their UB04, their 837I transaction. So we will talk about that a little bit today, how to set up, how that's going to work for those providers. As you are aware, especially if you've been working with Medicare at all, Medicare loves their acronyms. We use them every day. There's a lot of them. Today's session is not going to be an exception to that. So I will be utilizing some acronyms today. I did include those acronyms that I'm going to be using in the materials for today's session, just to make that a little bit easier for you to navigate and so that you have that available should you need them. So I'll like to start with just an overview of the requirements for a critical access hospital. So critical access hospitals are defined in the Program Integrity Manual 100-8, Chapter 10, Section 10.2.1.8. Now, one thing you're going to notice is the title of that section is Hospitals and Hospital Units. We are talking about a critical access hospital, and there are going to be similarities in the enrollment process for a critical access hospital, to those for a regular hospital. So they don't have their own section carved out, but there's many references in there. We're going to talk about that information today, but I wanted to provide that to you so you had that. And you'll notice Chapter 10, it's blue and underlined, so I've provided that link for you as well in the materials today. CAUSE are also detailed in the Code of Federal Regulations, and they are in CFR 485 subpart F. I'm not going to be going through this entire section for you. I am going to be covering the information included in this. However, as you get into your enrollment process for your particular scenario, this is a really good resource that includes some more granular detail, particularly when you get into some of the unique situations for locations, for qualifications, for personnel information. There's a little bit deeper dive into those details in the CFR. So I'm giving you that so that you have that for reference. Okay. So a critical access hospital to start their enrollment process is going to enroll very similarly, as I said, to a hospital. They're going to use a CMS 855A, and we're going to talk about how they will complete that. We'll focus on those differences, but there's going to be a lot of similarity again. Now, a critical access hospital, I want to be clear, is not eligible to be a subunit of a hospital. It is its own provider type. However, critical access hospital can have subunits. Typically, what we see here is that we'll see swing beds, so where we have acute hospital beds switching back and forth between acute hospital care and skilled nursing care. We will also see subunits often for rehabilitation units and psychiatric units. But where their requirements become a little bit different is going to be the fact that they are very rural. So a critical access hospital, to be eligible, is going to need to be located in a rural area or in an area that is treated as rural by CMS. Typically, this is going to be a facility that is 35 miles or more from the nearest, typically the acute hospital. Now that shrinks down to 15 miles if the CAH, Critical Access Hospital, is in mountainous terrain or is located in an area where there's only secondary roads. So a lot of it has to do with proximity to a larger facility. Critical access hospitals also are going to be really quite small compared to their counterparts, compared to an acute care hospital. And they are limited to having no more than 25 acute care beds in their facility. So again, super small. They're also going to have shorter acute hospital stays. They're going to have no more than 96-hour stays or less. And now this is an annualized average, so it's not necessarily by patient, but they're going to be shorter stays. Typically, if there's a longer stay, the patient's probably being transferred to another facility. Critical access hospitals are also going to provide 24-hour emergency care. So they're really meant to meet the need in a rural area where transporting patients or patients going to a hospital farther away is going to cause an issue with the care of that patient. A couple of other things I want to throw in here that are not on your slide, but I want to make sure that I mention them as we get into the enrollment process. Critical access hospitals are enrolling like a hospital, and they are also going to need to have a provider agreement, just like any other institutional facility enrolling on the Part A side would have. And I've asked Tom to put a link to the CMS 1561 provider agreement. This is something that will be signed by both the provider and CMS. And we'll talk about that a little bit as we get into their process, but I want to make mention that they are going to still maintain that provider agreement between CMS and the provider. And part of that agreement is the assignment of that PTAN. I want to make it clear as we get into this that the MACs are not assigning the PTANs for a critical access hospital or institutional providers for that matter. Because of their process, that provider number and the effective date for that provider number is something that is determined by CMS and communicated to the MAC. So it's something to keep in mind as we go through this. Touching on billing before we get into that enrollment piece, billing's a little bit different for critical access hospitals, or it can be. I should say it can be. CAHs are going to have two options, Method 1 or Method 2 billing. Method 1 is the default for critical access hospitals, and this is a cost-based reimbursement for the facility services. Not all that different to how a hospital would bill. They're going to bill like any other institutional provider. Like I've mentioned a couple of times, they are enrolling like a hospital, so unless they tell us differently, that is how they're going to bill. If there are professional services and the CAW has decided to maintain that method 1 billing as a default, professional services will have to be billed separately on a CMS 1500 or an 837P transaction. With that, though, there's going to be some additional enrollment actions. As I mentioned, the CAW is going to enroll on a CMS 855A, but that's again going to be for facility services. For any professional services that they have, they're going to need to enroll their organization on the Part B side. They would have to enroll as a group, and then they would have to enroll any professionals that are going to be billing professional services under that tax ID as a member of that group. Enrolling on the Part B side is the CMS 855B, much like a group clinic, if you're familiar with those. And then the members would complete that CMS 855I to reassign benefits. So if you have a service with both a facility and a professional component, you're submitting multiple claims. If it's method 1, we're going to submit through the UB04, the 837I transaction for those facility services, typical method 1 billing, and then the professionals are going to bill on the 1500 or the 837P, and they're going through different systems. The facility services would go through our FIS system, and our professional services are going to go through our MCS system. So just different claim systems. Now, method 2 is an option. Method 2 is still a cost-based reimbursement. However, for the professional services, there's going to be an additional payment based on the physician fee schedule for those services. And it's also going to allow that facility, that CAW, and this is a method unique to CAWs, they're going to be able to bill for professional services on that 837I or that UB04. We're going to talk about that here in a minute, but it's going to be a little more streamlined billing because it can all happen in one way. However, method 2 is not automatic. As I said, method 1 is the default, and method 2 does require election, and it does require election 30 days prior to the cost reporting period. And we'll talk about that more in a minute, but we do need those 30 days prior because there is an approval process involved with this. So I want to first talk about method 2 election. So the very first time that a provider wishes to elect billing method 2, they're going to need to submit a written request. And in that written request, which I do want to point out, there isn't a standard form. I would recommend the ones that I've seen. It generally comes in on the facility's letterhead and includes all of the key elements. And those key elements include written notice of intent to bill for method 2. It's going to need to have that cause name, their legal business name, and their provider number. So method 2 is not something that's typically elected necessarily during the enrollment process, though it could be. This election could be sent in with a critical access hospital enrollment application, but that provider number is going to be missing. That'll be something that'll be accounted for as we get there. So this generally, though, most often we do see it happen post-enrollment because that PTAN is going to be assigned. They have to identify the services, so the professional services that they intend to bill as method 2, and this can vary based on organization. So this will be something that each or individual organization is going to have to identify, determine, and account for in that election letter that's sent in. We're also going to need a list of the practitioners that are going to bill for method 2. And I want to be clear, those practitioners are going to have a bit of an enrollment process themselves, and we'll get to that. But that also means that you're only going to have to send in this election the one time. You're not going to send in this election every time that your organization adds or that CAW adds a professional to bill for method 2. So once we get this method 2 election letter, that written request, that does need to be forwarded on to CMS. CMS does need to approve this. The MACs are not approving this. Once they approve that, we take the appropriate actions into our system, allowing for that method 2 billing. And that method 2 election is going to be in effect for the entire cost reporting period. That is one of the reasons that we need that 30-day lead time that allows for that forwarding of that request to CMS, and it allows us to establish and make all of the changes that we need to in the system. Now, this is also a one-time election. Once it's elected, in the past, if you've maybe had to do this with an existing CAW that you work with, in the past, this was something that had to be elected on an annual basis. That is no longer the case. Once it is elected, it remains in effect, and the provider continues to be eligible for method 2 billing until they submit a written termination. So a written intent to terminate that. And that would have to be submitted, just like with the election, it needs to be submitted at least 30 days before the termination being requested. Again, allowing for that processing time. And one thing I do want to point out before I move on to the billing piece, there's also a link that's going to be shared with you that actually talks specifically about method 1 and method 2. And it talks about those reimbursement methods that we'll get into. And a lot of the links and the information for sending the election, that information is contained on this page. So it will show you what needs to be included here. It will talk about that enrollment process that we just went through. And then it also has all of the mailing addresses of where that needs to go in order to be considered. So let's talk about method 2 billing. The facility services, they're still going to be billed, as I mentioned, in the same manner that they have been. They're still going to be on the UB2. They're still being reimbursed and handled as if they're being billed method 1. The professional services that are indicated on that UB or the 837I transaction, once the election has been approved and all indicators have been put on that provider's file, those are going to be processed as method 2. But again, you're going to be able to put both the facility and the professional services on a CMS UB04 or an 837I transaction. Now, the providers that are going to be billing method 2 do actually need to be enrolled using a CMS 855I application. This is the same application that you would use if you're enrolling an individual physician to join a medical clinic. The process is not going to be any different. The sections that are completed are the same. Section 4F is the area of the application where you indicate this provider is reassigning benefits. You will list the critical access hospital as the group or organization to which the provider is reassigning benefits. You will list the critical access hospital's PTAN as the PTAN that will be receiving those benefits. Now here's where it starts to get a little bit different. Typically, when you fill out that form, you receive a notification letter that gives you a group member PTAN for the individual for which you completed that application. When the provider or when the individual provider is reassigning benefits to a critical access hospital, a PTAN or a provider transaction access number will not be assigned. You will still receive the approval letter, and it will tell you that this provider is reassigning to a critical access hospital. Here is their effective date. Here is the hospital that they reassigned to. Their MPI is now linked to that hospital, PTAN and their MPIs, so that you can bill method 2 for them. But no PTAN is going to be assigned. What this enrollment on What is seemingly the 850, the Part B side allows us to do is to link the CAW and the individual provider in our provider enrollment chain and ownership system. And that translates into our claims processing systems so that it recognizes the provider's MPI when it's listed on the UB04. So it's more of a record keeping piece, and it's going to line up with the intent. Now, any providers that were listed in that election letter showing that intent to bill this way, they're going to do that 855I, but that after you are initially set up, you just continue to send in 855Is if you are adding or terminating any providers with your organization. So it's going to feel a little bit like a Part B enrollment, but it is linking up to that critical access hospital. So it is truly setting them up for method 2. But those members will not have their own PTAN affiliated with that CAW. I also want to point out that not every individual provider specialty or provider type is eligible to connect themselves to a CAW for method 2 billing. It's a large portion of the specialties and the provider types out there, but it is not all of them. So it is all physicians, so your medical doctors and your doctors of osteopath, all specialties. They're going to be eligible to be set up to enroll as method 2 for their professional services. Physician assistants can bill method 2, as can clinical certified nurse specialists and certified nurse midwives. I apologize, I have a typo for certified nurse midwives. Nurse practitioners can bill method 2, as can clinical psychologists and licensed clinical social workers. Registered nurse anesthetists, this is actually where method 2 kind of started for us. So CRNAs are eligible to bill for that. Medical nutritional therapists have been added. And this year, with the new specialties for mental health starting in January of 2024, marriage and family therapists and mental health counselors are eligible to enroll for method 2 billing. And that information is also something that you can find in that CFR. It'll list out the types of providers that are able to bill. So if you're needing some documentation on who can bill, that would be your resource. So the enrollment process is going to work just a little bit different. But before I get into that, I do want to check in with Tom. Tom, do we have any questions in the chat?
We actually do have one question that came in. So for ER outpatient physicians billing, do we have to set up a new EDI through Medicare Part A to send electronic claims on the UB04 for method 2 billing?
If you are already set up to bill through EDI, and that emergency services are being billed through that setup, you would not need to set up a separate EDI for that.
Okay, next question. Sorry, we did get a couple, or at least one more in. Wouldn't the reassignment already be done on the enrollment as a cause original election?
So if the original election is coming in with just that letter, there's not an enrollment process involved in that. So that would be if there are existing providers already out there. So that 855I still needs to occur. That letter of intent is just letting us know that those are going to be connected. It's a little bit of a two-step process there.
That looks like it was our last question.
All right, excellent. So we'll move on to the enrollment process. So with the enrollment process, as I mentioned, it's a little bit more involved than just submitting in the application. And this is true of all institutional providers because CMS really wants more oversight. We're talking higher dollar claims, and so they just want to make sure that we're all on the same page when we do the enrollment, and they want some say in that enrollment process. So the way that works is that the provider is going to send in the CMS 855A application to the MAC. The MAC is going to screen and verify all of the information that's contained on that application, and they're going to have one of two paths. Either everything is there and it can continue on to what we refer to as our certification and survey process, or there is some development that is needed. I want to be very clear that that certification and survey process doesn't happen until we have received all information needed to recommend that application for approval. So it has to be a complete and fully vetted application before it moves on. So if there is development, that development process has a 30 calendar day timeline. And so that could potentially cause for a slightly longer processing time if we have to develop for information. So something to keep in mind. Once we have all of the information on the application and we have vetted all of the information, we verified everything, the MAC is going to refer that to the state agency and the state operations group. And they are going to do their review based on their guidelines. And those are separate from the MAC's guidelines. It may involve a state survey. I will tell you, if you have any type of accreditation, you're going to want to include that in your enrollment application. As part of those accreditations, there's generally already some type of site survey included in that with the same guidelines as the state agencies or the state operations group, and it can help that certification and survey process go more smoothly. So if you have accreditation, certainly not required, but if you have that, send that, because that'll certainly help the process along. Once the state agency and the state operations group have made the determination, they will respond to the MAC, and we will take any additional steps as identified by that state agency or state operations group. That could include, we need to develop for some clarifying information. So we may have an additional development that has to happen. Also, we'll talk about this, but critical access hospitals are subject to a Medicare site visit. That would be the time that that site visit would occur. And we'll talk about that a little bit. Once we have all of the needed information, the needed actions taken care of from that notification, we as a MAC or the MAC is going to complete that enrollment. And that is going to include notification of the PTAN and effective date and being able to bill. As far as a timeline on this piece of the process, it varies. So the initial screening of that CMS 855A, that needs to happen depending upon its submission type within, and if it's clean, within 15 or 30 days. It's standard application processing timeframes. State agency and SOG reviews can actually, that's where it can vary. It depends on how involved they need to get, what their workload is at that time. So unfortunately, I can't speak to that. I will say, though, for initial enrollments, we do sometimes see these be taking just a little bit longer, and we're working with them. However, there are also some scenarios, if we're making simple changes, where this process is not required, and that processing time is just based on the application processing. So moving on to the application itself, I'm going to talk about how applications would be submitted for a CAW, and we are going to talk about some of the differences between how it's submitted electronically or through paper so that you can see the comparison of the two. So first and foremost, submitting applications, there's two ways to do it. You can either do it electronically through our provider enrollment chain and ownership system, and you'll notice that I've included a link to both the electronic and the paper application here. But you would submit electronically, you would select that you are a critical access hospital, and the system's going to ask you a series of questions that are going to lead you down the appropriate path for a critical access hospital, whether that's an initial, whether it's a revalidation, whether it's some sort of a change. It's going to essentially customize and tailor that application to what you need based on what you're telling it. It works a lot like some of the do-it-yourself tax software, if you're familiar with any of that. So it'll walk you through that. The paper application, conversely, that is available on the CMS website. Again, I've provided that link. It is a template, and it's a PDF template, and you can fill out the fields in that template without having to handwrite them. They can be typed. In fact, they have to be typed. However, you cannot fax that. You cannot email that. A paper template, paper A55I, or excuse me, A is going to have to be printed, and it's going to have to be sent to us regular mail. Again, cannot be faxed, cannot be emailed. If we receive an application faxed or emailed, we're going to develop for you to send it in, and that is per CMS regulation. So from a processing standpoint, I am always going to advocate for PACOS, and that is because the processing time is significantly reduced. If we have all of the information that we need, we process electronic applications within 15 days. That's calendar days, so weekends and holidays count in those 15 days. And for a call, what that means is within those 15 days, we are getting that to the state agency or the state operations group, that SOG, for their review. So it's significantly faster. With paper app, because it's got to be sent in regular mail, it has to be opened, it has to be ingested into our system, and then it's manually processed. And while we have some automations, we have some data entry automations available to us in PACOS that cause that process to go a lot more smoothly. Paper is more involved, so it can take up to 30 calendar days. So again, further delaying that process. So if you haven't already started leveraging PACOS, I do recommend you try it and check out our YouTube channel. We do have an encore that we did in the last few months that is a PACOS Basics encore, and it talks about setting up, making connections in there to submit on behalf of providers, and then just how to get started with with several application types. So for the required sections, as I mentioned, PACOS is going to ask you a series of questions, and in that it's going to ask you, what are you trying to do? In this example on the left, you're seeing the questionnaire where it's asking the type and you're telling it you're creating an initial enrollment. You can also perform changes, revalidate, complete changes of ownership, and deactivate records. So those are the options that you have in PACOS. Pretty much anything, anything you have available to you on paper. On the right side, you're seeing those same choices, but on the paper application. And what you'll notice is that on the paper application, the second column is giving you a list of the sections that are required, and not necessarily based on specialty. That's fairly universal. But it's just going to give you the list of the sections, whereas PACOS is just going to present you those sections as you go, and you're not going to have to keep track. When you are getting to section 2, this is where things look a little bit different for cause as well. This is where you're going to want to select the appropriate provider type. You're going to want to make sure you're selecting critical access hospital and not just hospital. The option is available both on paper and in PACOS, as you can see here. One caveat with PACOS, this is something that if the wrong selection is made at submission, it's not something that we can fix on the MAC side. Typically, we'll do everything that we can to avoid a resubmission for you, but it's not something that can be changed. So just make sure that you're being conscious of that and you're selecting that correct provider type. We do see that from time to time for all provider types. Section 4 is another area where you will notice things just a little bit different, not a lot. We do need to list all locations that are owned and operated by the CAW here, and there have been some changes to this section, and one of them is indicating which location is the primary location. That does need to be reported to CMS, so we're asking for that indicator here. And then you're going to indicate the type of practice location. And by type, is it a psychiatric unit? This is going to be those subunits we talked about earlier. Is it a psychiatric unit? Is it a rehab facility? Is it perhaps a swing bed? Those are all things that you're going to want to indicate for each facility. That goes into that review process with the state agency and with CMS. So documentation for CAW. Those are really the only two sections that are going to be a little bit different for CAW. Documentation for CAW, we're going to be looking for copy of license and accreditation. As I mentioned before, if you are accredited, that's something you're going to want to share with us because it can help that certification and survey process go more smoothly and get you to that final enrollment decision, approval, and ultimately your P10 a lot more quicker, get you billing a lot quicker. We are going to need tax ID verification. So we're going to need something that's showing the legal business name and that is showing the tax number as it's reported on the application. Typically, the forms that we see are going to be the CP 575 and the 501c3. That 501c3 is going to, what's your nonprofit status? If that is the case, we're just going to make sure we need to see that. One thing we see here is that sometimes the legal business name does not match. Perhaps it's a longer legal business name and it's shortened. We don't have all of it on that form. We do actually need to be able to see that entire name. If you don't have either of these forms, we're looking for something that has been printed out of an IRS computer. It can't be handwritten. It can't be a letter from the authorized delegated official. It has to be something on file with the IRS because the IRS will do a compare on our legal business names to theirs. And there's sometimes a backup withholding that occurs if they do not match, and we're trying to avoid that for you. Organizational flowcharts. This is not always required, but it is required if reporting organizations with ownership or managing control in Section 5 of the 855A application. So holding companies, management companies, parent companies, those would be reported in Section 5. And if they are, we need a copy of that organizational flowchart because we're using that to confirm that all entities with ownership in the enrolling provider have been reported to us. And they're usually simple. Most all organizations have them. We see them from complex with a ton of boxes and lines showing business relationships to something that is just a few of them. So whatever your organization has, we're going to be looking for that. I do want to point out that is something that was a flexibility during the COVID-19 pandemic. We are seeing that we do develop for these because a lot of people are thinking that that flexibility is still in place. That is not a flexibility that was extended. That was actually a flexibility that ended before the public health emergency was lifted. So make sure that you're including those. Next is the CMS 588 electronic funds transfer agreement. So this is for electronic payment. This is only needed in certain circumstances. It's needed for all initial enrollments. And if there's a change that impacts the account holder or the account information, so things like the name on the account, the routing number, the account number itself. If there's a change to that, we're going to need that. That's true on changes and revalidations. Something that we see is we're starting up revalidations again. We're seeing providers filling out that CMS 588 electronic funds transfer agreement, and it was needed in the past. CMS has stated that we do not need to get a CMS 588 electronic transfer agreement from the provider again during revalidation unless something about that account or account holder information has changed. So that's an item that you can stop doing if you are, save yourself a little bit work. If you are, however, sending in that 588 because it applies, we do need account verification documents. That would include a voided check or a signed bank letter. Starter checks are not eligible, and as far as a signed bank letter, anyone from a teller to the president of the bank can sign that. It doesn't have to be a specific rank for that. but it does need to be from the bank, not the authorized delegated official of the entity. The other thing that I want to point out from a documentation perspective is adverse legal action documentation. If adverse legal action is being reported in either Section 3 of the application or Section 5 or Section 6, we do ask for that information on owners and anyone or any entity with managing control. We need a copy of those adverse legal documents. Again, having an adverse legal action in history doesn't necessarily preclude a provider from enrollment, but we need to have all of the information to confer with CMS to make that enrollment decision so that we know whether or not it's something we need to be concerned with or just something that we need to maintain in our records. Before I check in for questions, I do want to point out that critical access hospitals are in the limited risk category, so they are not typically going to be included in the requirement for a site visit, but there are times where they may need one. And again, that has a lot to do with what comes back to us from that state agency and that SOG, so keep that in mind. However, they do fall into the category where an enrollment fee is required. Anytime they're sending in an application for an initial enrollment, a revalidation, or adding of a practice location. And what you're looking at here is a matrix that CMS has created for indicating which providers and which enrollment application reasons require an enrollment fee. So initial enrollments, again, revalidation and the addition of practice location. And that addition of practice location is not for a move. If one location closes, the facility moves and they report the new location, that's not a scenario that requires that enrollment fee. Addition of a practice location requires a fee if it increases the total number of practice locations currently on file for that provider. So it's a net gain in practice locations where CMS requires that. And for 2024, that enrollment fee is $709. So something to keep in mind. And again, that resource is provided in your links for today. Here I am providing you with some CMS resources out there. There are some Med Learning Network articles that are out there, and there are some compliance pages along with that Code of Federal Regulation and that CFR that I spoke to you about. Because we did not talk about specifics with billing beyond Method 1 and Method 2 today, I wanted to provide you with a little bit more information. And these articles, these links contain some more detailed information and resources for you specific to claims and billing and different scenarios that you may have. So you have those. And then also we have 3 articles that talk about enrollment. So everything we've been focusing on today, and Method 1 versus Method 2, including how to elect that, the requirements for that enrollment. And then again, we also have an article that has some information regarding reimbursement and payments for critical access hospitals. So with that, I'm going to check in with Tom again. Do we have any questions in the chat?
Sure do. Start with our first one. They were approved in 2024 for Method 2. Do all providers have to do another 855I? In 2023, they were approved as a critical access hospital.
Excellent question. In that instance, no. You were enrolled in 2023 and you were actively billing. So those connections were all already made. The election requirements have changed in the last couple of years, so that timeline's telling me you're falling into that. So if you are currently billing Method 2 for those, you do not need to submit an 855I for those existing providers. Any new providers that you may add are going to need that 855I because they won't automatically be registered, and you won't be able to do that through just that letter. So you're grandfathered in with those that you've been set up with since 2023. Now that it's 2024, you add somebody this month, they're going to need that 855I.
All right, so next follow-up question to that, is there a department that we can call at WPS that would be able to inform us if we are clear to send claims on the UB04 instead of the 1500 for Method 2 physicians?
You'd be able to reach out to our call center and they would be able to selecting the provider enrollment option, and they would be able to take a look at that provider and confirm that for you.
Okay. Next follow-up question to that, if we're clear to bill Method 2, if we have to bill on a UB04 for physicians, would we send the EDI claims to the payer ID for A or for Part B?
Excellent question. They're going to be billed essentially like a Part A claim. That connection that we make in the provider enrollment area is actually connecting that provider's MPI in the FIS system, so in that Part A claim system, so that it will pay the professional charges on that UB04.
That is our last question.
All right. So that ends the presentation for today. On behalf of myself and everyone, Tom and everyone with GHA Provider Outreach and Education, I would like to thank you very much for taking time out of your day for joining us today. Our goal again is to provide you with that best possible customer experience, and we look forward to your survey comments, including any feedback that you have for future education that you would like to see and that you would find helpful. So again, thank you. Have a great day. Have a great holiday weekend. You may now disconnect.